Welcome back to the Deep Dive. We're tackling a subject today that I think a lot of people mistakenly view as just, sniffles and earwax.
Mm-hmm.
But when you actually peel back the layers, you find this medical field that is just a study in extreme contrasts.
It really is.
On one side, you have the most delicate, microscopic engineering in the human body. Tiny bones that vibrate, membranes thinner than paper. And then in the very next room, you've got these high-stakes, adrenaline-pumping emergencies where a few millimeters of swelling is the difference between life and death.
You're shifting gears constantly. It's a unique specialty for that reason. We are talking, of course, about otorhinolaryngology.
Or, as it's more commonly known, ENT.
Much easier to say.
Exactly. And to guide us through this, we are diving into ENT, an Introduction and Practical Guide, 3rd edition, edited by James R. Tyson and Rahul Kanegamankar. And this isn't just a textbook. It feels more like a manual designed for the trenches.
Oh, absolutely.
The mission here seems to be bridging that gap between the dry anatomical theory we learn in the classroom.
Right, the diagrams and the Latin names.
And the messy, on-the-ward reality of managing emergencies, examinations, and, well, surgeries.
And that gap is where the danger lies for new doctors. You can know the anatomy of the neck perfectly on paper, but if you don't know the tactile sensation of a malignant lump versus a benign cyst, the book knowledge won't save you.
That's a great point.
This text is really for medical students, trainees, people in primary care who need to know not just what a structure is, but how to look at it, how to fix it, and crucially, when to panic.
When to panic is probably the most valuable lesson in medicine. So we have a lot of ground to cover. We're going to look at the anatomy of hearing, the art of the physical exam, the bread and butter pathologies, airway emergencies.
Which get into some fascinating physics.
Right. And finally, the surgical side of things.
Including some key updates in this 3rd edition on hearing implants and vertigo management. It's a comprehensive review, so let's get into it.
Let's start with the ear. I have to say, I never realized how complex the simple outer ear, the pinna, actually is. The source mentions it develops from 6 hillocks of his. It sounds like something from a fantasy novel.
It does sound mythical, doesn't it? But it's essential embryology. These 6 little islands of tissue, they arise around the 6th week of fetal development. And they have to migrate and fuse together perfectly to form the ear shape we recognize.
And I imagine because it's a fusion process, things can go wrong at the seams.
Precisely. If those hillocks don't fuse perfectly, you get these little pits called preauricular sinuses. You'll see them right in front of the ear. They look innocent, just a tiny dimple, but they can track deep into the tissue and are prone to getting infected.
Wow.
It's a reminder that the anatomy is a fused puzzle.
But the part that really blew my mind was the ear canal skin. The text calls it an escalator mechanism. I think most of us assume skin just kind of sits there.
But the skin is actually going somewhere. It's one of the body's most elegant self-cleaning systems. See, the ear canal is a cul-de-sac, a blind alley. If dead skin and wax just piled up like they do on your arm, the canal would be blocked in months. So the skin of the eardrum in the deep canal, it's unique. It migrates. The top layer of keratin sheds tangentially, moving outwards from the eardrum towards the exit.
So it's a literal conveyor belt carrying wax and dust out of the ear.
Correct. And this brings us to the #1 enemy of the ear canal, the cotton bud.
Ah, the Q-tip.
When you stick a Q-tip in there, you are mechanically disrupting this escalator. You might get a little wax out, but you're mostly just pushing the rest of it back against the flow, impacting it.
You're fighting the machine.
Exactly.
Yeah.
You're stripping the natural oils, creating microabrasions, and giving bacteria a foothold. The best thing you can do for the escalator is to just leave it alone.
Respect the escalator.
Yeah.
Got it. Now, let's go a bit deeper to the middle ear. The book talks about impedance mismatch. This sounds like we're discussing electrical engineering, not biology.
It is physics, plain and simple. Sound waves travel through air, right?
Yep.
But the inner ear, the cochlea, it's filled with fluid. If sound waves hit that fluid directly, most of the energy would just bounce off. Think of trying to talk to someone who's underwater while you're standing by the pool.
They can't hear you. The sound just reflects off the surface.
That is impedance mismatch. We'd lose about 99.9% of the sound energy. We'd be functionally deaf. The middle ear's whole job is to act as a transformer to bridge that gap.
So how does it boost the signal enough to push through that fluid?
2 ways. First, there's a small lever action from the ossicles, the little bones. But the massive factor is the area ratio. The eardrum is large, while the footplate of the stepes, that's the bone that pushes on the inner ear, is tiny. The ratio is about 17 to 1.
It's like a woman in stiletto heels stepping on your foot. All that weight concentrated on one tiny point.
That is the perfect analogy. You are concentrating the force. That mechanism alone gives you a sound pressure boost of roughly 33 decibels. It's a brilliant solution.
Before we leave anatomy, we have to mention the facial nerve. It seems like it's almost dangerously tangled up with the ear.
It is the bane of the ear surgeon's existence. Cranial nerve 7th, it takes this really tortuous path right through the temporal bone, weaving around the middle and inner ear structures.
So an infection in the ear can actually paralyze your face.
Yes, because the nerve is trapped in that bony canal. If it swells from a viral infection like herpes zoster, it gets strangled.
Oh, wow.
That's Ramsay-Hunt syndrome. You see blisters in the ear canal, and the patient has facial paralysis on that side. It just shows how tight the real estate is inside that bone.
Okay, let's move from theory to practice, the exam. The book has a golden rule: comfort and level positioning.
It sounds so basic, but it's critical. You are inserting instruments into small, sensitive holes in the head. If you or the patient are twisting or stretching, you lose fine motor control. You will hurt them, or you'll miss the diagnosis.
And speaking of instruments, the text is very specific about otoscopy. Hold the otoscope like a pen. Why is that grip so important?
Safety, 100% safety. Never hold it like a hammer. If you hold it like a hammer, your hand is rigid. If the patient sneezes or jerks their head, which kids do all the time, your rigid hand drives that speculum right through their eardrum.
Ouch.
Yeah. But when you hold it like a pen, you rest your pinky finger on the patient's cheek. That's your anchor. If the patient moves, your hand moves with them. It's a safety buffer.
That's a great practical tip. Now, the neck exam. The text breaks it down into triangles. But there was one clinical pearl that really stood out as a major warning sign.
This is one of the most important takeaways for any clinician listening. In a child, fluid in the ear, glue ear, is common, usually benign. But in an adult, it is not.
So if you see an adult with fluid behind one eardrum and they haven't had a cold,
The alarm bell should be ringing. You have to ask why.
what's the connection?
The plumbing. The eustachian tube drains the ear into the back of the nose, the postnasal space.
Yeah.
If an adult has fluid in one ear, something might be blocking that tube. And in the worst case scenario, that something is a nasopharyngeal tumor.
So you have to check the back of the nose.
You have to. Unexplained fluid in one ear in an adult demands an examination of the postnasal space to rule out cancer. It's a life-saving pearl.
It really is. Okay, let's move to the bread and butter pathology. Otitis externa.
Swimmer's ear. Usually triggered by water or, again, those cotton buds. It's painful, itchy, the canal swells shut. But the text distinguishes between that and something much darker, malignant otitis externa.
The word malignant usually means cancer, but not here, right?
Correct. It's a historical misnomer. It's not a tumor, but it behaves with malignant aggression. It is an osteomyelitis, a bone infection of the skull base. It typically affects elderly diabetics or the immunocompromised. The bug is usually Pseudomonas aeruginosa.
And the red flags. How do we tell the difference?
Pain. Severe, unremitting, deep pain that is way out of proportion to what you're seeing. It keeps them awake at night. And visually, you look for granulation tissue, this fleshy, raw, red tissue on the floor of the ear canal.
And if you miss that,
If you miss this, the infection spreads to the cranial nerves at the skull base, and it can be fatal. It needs IV antibiotics and a CT scan, not just eardrops.
let's talk about something a bit messier. Epistaxis, nosebleeds. The text identifies a specific hotspot for these.
Little's area, or Ketelbeck's plexus. It's on the anterior nasal septum. It's where 5 different arteries all meet, so it's a high-pressure vascular junction. This is where most nosebleeds come from.
And the management. What's the first step?
Simple first aid. Pinching the soft, cartilaginous part of the nose, not the bony bridge, for a full 10 to 15 minutes. If that fails, and you can see the vessel, the text recommends silver nitrate cautery.
To burn it shut.
Exactly. Shoving a sponge in there is second line. It's uncomfortable, risk of infection.
But there's a condition where the book says, do not pack. Hereditary hemorrhagic telangiectasia, HHT.
Yes. These patients have fragile, malformed blood vessels all over their nasal lining. They're like wet tissue paper. If you shove a pack in there, it might stop the bleed temporarily. But the pack sticks. When you pull it out, you just rip everything open again.
So you cause more bleeding than you started with.
It's a vicious cycle. You have to be much gentler with those patients.
One last bread and butter topic.
Yeah.
Foreign bodies.
Mm.
Kids putting beads up their noses. The text mentions the parent's kiss.
I love this technique. It uses positive pressure. If a child has a bead in their right nostril, the parent places their mouth over the child's mouth, making a seal. You plug the good nostril with the finger, then the parent gives a sharp puff of air.
And the air has nowhere to go but out the other nostril.
Exactly. It pops the foreign body right out from behind. It's effective and way less scary than using instruments.
What about fish bones in the throat?
Classic ER visit. The key note here is about imaging. Don't rely on x-rays. Many fish bones are radiolucent, they don't show up. But the patient is usually right. If they point to a spot and say, it hurts here, you have to believe them and go looking for it.
Moving from the clinic to the emergency room. Airway emergencies. The text brings up Bernoulli's phenomenon.
This explains why a narrowed airway is so unstable. Bernoulli's principle says that as the speed of air increases, its pressure decreases. So in a narrowed airway, the air has to speed up to get through.
Okay, so the air rushes faster through the tight spot.
Right. And because it's moving faster, the pressure inside the airway drops. That negative pressure then sucks the walls of the airway inward.
It collapses the straw while you're trying to drink.
Exactly. And the harder the patient tries to breathe, the faster the air moves, the lower the pressure drops, and the more the airway collapses. It's a terrible feedback loop.
That is terrifying. So how do we manage it? The book mentions heliox.
Heliox. It's a mix of helium and oxygen. Helium is much less dense than nitrogen, so it flows with less resistance. It turns that turbulent, crashing airflow into a smoother, laminar flow. It reduces the work of breathing and buys you time.
And when you're assessing these patients, the sounds they make are vital. Stridor versus stridor.
It's your GPS for the blockage. Stridor is a low-pitched snoring sound that comes from the pharynx, big tonsils, tongue falling back.
Got it.
Stridor is high-pitched, musical, or harsh. That means the problem is lower down in the larynx or trachea. Hearing the difference tells you exactly where the enemy is.
Let's head to the operating theater. Surgical interventions. Adenoidectomy. It seems the technique has changed a lot.
It has. Traditionally, we used curettage, basically blind scraping of the adenoid pad behind the nose. It's quick, but bleeding can be hard to control, and you can leave tissue behind. The text advocates for suction diathermy.
And how is that different?
It uses a camera for visualization and a device that sucks and cauterizes at the same time. You can see what you're doing. The text notes specifically. Less blood loss, better visualization, and less risk of regrowth.
Now for the ear. Mastoidectomy and stapedectomy. They sound similar, but are for totally different reasons.
Completely different missions. A mastoidectomy is usually about safety. You're drilling out the mastoid bone to remove chronic infection or a cholesteatoma, that destructive skin cyst. The goal, as the book says, is a safe, dry ear.
So function is secondary.
It is. A stapedectomy, on the other hand, is for otosclerosis, where the States bone gets fixed in place. That surgery is all about restoring function. We replace the fixed bone with a tiny piston to bring hearing back.
And finally, nose jobs. Rhinoplasty versus septoplasty.
A septoplasty is purely functional. It's straightening the partition inside the nose to help you breathe. A rhinoplasty changes the outside look, and when you do both, it's a septorhinoplasty.
Okay, moving to head and neck. We are back to the rule of thumb territory, neck lumps.
This is a rule you just cannot forget. In an adult, a neck lump is malignant until proven otherwise.
That's a very stark rule. No, let's wait and see.
Not in an adult. You assume cancer, you do a thorough exam, you use ultrasound and fine needle aspiration to get cells. You look for red flags like a hoarse voice or difficulty swallowing. You never just watch an adult neck lump without a diagnosis.
And finally, the spinning room. Vertigo versus dizziness. The text makes a clear distinction.
It does, and the language is key. Dizziness is vague. It can mean lightheadedness, unsteadiness. Vertigo is a specific hallucination of movement. The patient feels like they are spinning or the room is spinning.
And this all ties into the balance triad.
Right. Your balance depends on 3 inputs: vision, proprioception, so, feeling the ground, and vestibular input from the inner ear. If there's a mismatch, that's when you get vertigo.
The text mentions BPPV as a common cause.
Benign paroxysmal positional vertigo. It's caused by little calcium crystals getting loose and floating into the semicircular canals. It's a mechanical problem. Every time the patient turns their head, the crystal moves, the fluid moves, and the ear screams, "We are moving," even when they aren't.
All right, we have covered a mountain of material. To wrap this up, let's do a quick review exercise. I'm going to give you a scenario.
I'm ready.
You have a diabetic patient, 65-year-old male. He presents with severe, deep ear pain that's been getting worse for weeks. On exam, you see granulation tissue on the floor of the ear canal, and crucially, he has a slight facial nerve weakness on that side. What's the diagnosis and what's the bug?
That is the classic presentation we discussed. The diagnosis is malignant otitis externa, and the causative organism is almost certainly Pseudomonas aeruginosa.
And the plan.
This is a medical emergency. The facial nerve weakness tells you the infection has already spread into the skull base. He needs urgent admission, a CT or MRI scan, and long-term intravenous antibiotics. If you treat this as simple swimmer's ear, you could lose the patient.
Excellent. It's a sobering reminder of why this specialty matters so much.
It really is.
We started by talking about the microscopic hillocks of his and ended with life-threatening skull base infections. ENT really does span the whole spectrum.
It does. And if I can leave our listeners with one final thought from the text, it's to go back to that escalator mechanism of the ear.
Right.
It was such a perfect example of the body's self-cleaning engineering.
And how we ruin it.
Exactly. We disrupt that elegant system with our fingers and cotton buds. The best thing you can do for your ear anatomy is usually to just leave it alone and let it do its job.
Respect the anatomy, that's the lesson. Thank you for listening to this deep dive into ENT, an introduction and practical guide. Hopefully you feel a little more prepared for the wards, or at least you'll think twice before putting a Q-tip in your ear. See you next time.